Good afternoon, everyone. I'm Rich Walitsky, and I'm the Deputy Director for Behavioral and Social Science in CDC's Division of HIV/AIDS Prevention. And it's my pleasure this afternoon to be able to welcome you on behalf of the division and on behalf of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. I want to thank you for coming today and being a part of what I think is going to be an incredibly interesting and intellectually stimulating discussion. I want to let you know that in addition to those of you who are here with us in the audience today, we're also being joined by people around the country and around the world who are watching today's event via live web stream and are twittering about it. Or tweeting about it, I guess I should say, showing my age and my experience here. So, as you know, this month marks 30 years since the first cases of what later became known as AIDS were reported in CDC's MMWR. And today's session is one in a series of lectures that are being conducted throughout the summer that commemorate the unwavering commitment of public health professionals to the fight against HIV. This lecture series is designed to raise awareness about the important successes that have been made over the past 30 years and to provide an opportunity to reflect on the hard-won lessons that we've learned over these many difficult years. Today we'll have a chance to hear from some of the public health leaders who've made critically important contributions to the evolution of HIV testing and the fight against HIV. It'd be hard to overstate the importance of their contributions and the contributions of HIV testing to public health, healthcare, and the lives of people living with HIV and affected by HIV. In my mind, the availability of HIV testing is clearly one of the top 3 critical breakthroughs since the HIV epidemic began. The availability of HIV testing made it possible to screen blood products and virtually eliminate HIV transmissions associated with infected blood products. HIV testing reduces risk behavior among those who are living with HIV, and it's a critical element in the prevention of mother-to-child transmission. The importance of HIV testing is evidenced by the fact that after testing was approved by the FDA in 1985 and scaled up along with other HIV prevention programs, we saw a dramatic decrease in the number of new HIV infections in this country. Now, HIV testing is a critical first step to improving the health of people living with HIV. People who don't know that they're infected can't get the health care and the services that they need. Now, in this era of effective HIV treatment, it's a little hard to think back and remember what it was like in the early 1980s before HIV testing became available. The fear that existed at that point in time was sometimes overwhelming. Before we had HIV testing, you had no way of knowing if you, someone you loved, or someone you had made love with had HIV until you became sick and developed symptoms. Testing gave people who were at risk for HIV a way to take greater control of their destiny, to take steps to protect themselves if they were negative, and to take steps to manage their own health and protect others if they were positive. Getting tested back in those days was not without controversy. It was a time when we did not have effective treatments for HIV, and there were very real concerns about confidentiality and what might happen to those who tested positive. Back then, testing positive meant that you had to face not only the possibility of an early death, but also the widespread stigma, discrimination, and rejection by friends and family that were common back in those days. It's important, too, that we don't forget about the importance of HIV testing on the lives of people today who are worried about the risk of infection and are trying to reduce that risk, as well as the impact that HIV testing has on the lives of those who are diagnosed with HIV. For those of us who've tested positive, That testing event and that brief moment in time when you learn that you are living with HIV is one that stays with you for a lifetime, and it changes your life forever. Fear, stigma, and discrimination have not completely gone away, but they've gotten better. And fortunately, we're now in a time when there is effective treatment, and knowing your status and acting on that knowledge means that instead of facing death, people living with HIV are now facing the possibility of having long, healthy, and productive lives. This change has truly been miraculous. Now I'd like to turn the session over to my colleague, Dr. Michelle Owen. Dr. Owen is the leader of the HIV Incidence and Diagnostics team in the laboratory branch of CDC's Division of HIV/AIDS Prevention. Her laboratory conducts research to develop, evaluate, and implement new diagnostic technology, and specific areas of research include evaluation and development of HIV diagnostics for the detection of antibody, antigen, and nucleic acid, and development of tests to distinguish recent from long-term HIV infection. And her laboratory is also currently investigating new HIV diagnostic algorithms to improve diagnosis. In addition to this research, Dr. Owen is also responsible for the oversight of the CDC HIV CLIA reference laboratory, which provides HIV diagnostic support to public health laboratories, epidemiologists, commercial labs, and physicians. Dr. Owen has worked in retrovirus research at CDC since 1989, and from 1989 to 2003, her research was focused on HTLV and HIV pathogenesis and immunity. In 2004, she assumed the role of diagnostics activity lead in the laboratory branch of DHAP. I'm going to stop there, Michelle, and I'm going to let you take it from here.
Okay, great. Thank you, Rich. And I also want to welcome everyone once again. I think it's going to be a wonderful session, and I'm really honored to actually sit up here with all these guys, a wealth of knowledge at this table. So hopefully I won't let them down my moderating burden. So first of all, and I'm going to do some brief introductions of the speakers. I'll introduce them when they start to speak. So I'll introduce Dr. Cowan first, then we'll let him speak. And I will ask if you have questions, unless it's a real clarification question, if you can hold them to the end, please, because we have a lot of information to get through. But we'll have about 30 minutes of discussion, so I certainly hope you'll all be able to get your questions in. So our first speaker is Dr. Eliot Cowan, and he's from the FDA. Dr. Cowan's also been working in the field of retroviruses for quite a long time. He finished his Ph.D. in 1983. He had worked for NIH. He did a lot of work with HTLV in his early career. And then in 1993, he actually came to FDA and in CBER. So welcome, Dr. Cowan. I think he's going to tell us about the successes with screening the blood supply.
Thank you, Michelle, and thanks to the organizers for including FDA. It really is an honor to be here, and I'm delighted to be the one to represent the agency. I also wanted to point out that the title of this session is The Evolution of HIV Testing, Then, Now, and Beyond. Given that there are 3 speakers, I guess that means I am then. So I guess I'm the old stuff. Dr. Branson is the present, and Dr. Cohen is the future, so we'll see how this plays out. But having said that, I think it's also very important for us to understand really where it is that we've come from. And so I'm going to be talking about HIV screening as it first began and give you a bit of a history. And I think that the history of testing is best described on this slide right here, which is a graph. I usually start out with some bullets just to say what I'm going to tell you, but I think this slide really tells it all. I'm going to take you on a journey, which is going to be shown by this little blood drop that's moving along, that's infected with HIV. And we're starting with the first cases of HIV reported, of course, in 1981, which is why we're here. And then the first case of transfusion-associated HIV, which was reported in 1982, after which high-risk donor deferral was initiated. As a result of that deferral, then the peak was reached in, after the peak was reached in like 1982 and 1983, with the discovery of HIV, then there was a progressive impact of high-risk donor education, and the rate of transfusion-transmitted infections dropped. And finally, when anti-HIV screening was implemented, there was a precipitous drop in the number of transfusion-transmitted infections. I really could stop there. That's the message. But instead, I will go fill out my 15 minutes with a bit more of the history. Again, the starting point here, if you'll notice, these are cases of transfusion-associated AIDS that were reported to CDC by year, and what you can see that by 1983, there were a total, in some cases, there were 700 transfusion transmissions that were associated, transfusion transmissions of HIV. To give you some other numbers, I'm just going to drop in some other drops here. 12,000. 12,000 was the number of HIV transfusion-transmitted infections in the early 1980s. 8,000. 8,000 is the number of HIV infections that were transmitted to hemophiliacs in the early 1980s, presumably through contaminated blood products such as factor VIII. And finally, 1.1%. This represents the risk of transfusion-associated HIV-1 infection per transfused unit in some locations in 1983. So in other words, we had some very, very serious threats to the safety of the blood supply back in '83. Now, FDA is responsible for the safety of blood and regulates all aspects of blood safety, and there's an approach that we have called the 5 layers of safety, including the donor eligibility, and this includes self-deferral and screening, filling out the donor questionnaire. The second is laboratory testing and deferral, then quarantine controls to prevent unit release pending verification of donor suitability, investigation and correction of deviations when mistakes are made, and then follow-up inspections to make sure that those deviations have been corrected, and finally, donor deferral registry so that people who return who are infected are recognized and not allowed to donate. Of course, I'm going to be concentrating on number 2 here, laboratory testing and deferral. With that, I'm going to take you through a timeline, which right now is kind of empty, but you're going to see it's going to be very filled by the time we get to the end of it. We'll start again in 1983, in which we're starting with paper instead of tests. And this paper was recommendations issued by Public Health Service for deferral of at-risk donors. That was followed in 1985 with FDA's approval of the first enzyme-linked immunosorbent assay, it's used to saying EIA or ELISA, to screen for antibodies to HIV-1, followed a couple of years later by the first Western blot, recognizing that the screening test that was approved in 1985 was identifying more people identifying people as infected when they actually weren't. So the mandate was to have an additional, more specific test to determine if the initial screening test was actually a true positive or not. That was the Western blot, again approved in 1987. This takes us to 1988. Once the screening was implemented, regulations were implemented requiring HIV testing of blood and plasma donors. In 1990 and 91, FDA licensed the first test to detect HIV-2, recognizing that the existing tests had some trouble in detecting HIV-2, and the tests that were licensed were EIAs that were detected either HIV alone or the so-called combi tests, combination tests, to detect both HIV-1 and HIV-2 antibodies. This takes us to 1995, in which at that point, FDA was recommending that blood establishments implement donor screening for HIV-1 antigen using licensed test kits. Of course, at that time, there were actually no tests that were licensed. But this was designed to have recommendations in place so that when the first test was licensed, which was in 1996, that could be implemented immediately. In 1997, the first HIV nucleic acid test, IND, went forward for source plasma. And then in 1999, HIV NAT IND studies were initiated for the US blood supply. Now, these were investigational studies that were designed to collect data to support the approval of a license application for these tests. While it would seem that the investigational studies may be trivial, in fact, they were not, because what happened was that essentially all of the blood in the US was being tested under IND, and so even though there was not a licensed test, the investigational test was actually used to screen all of the blood donors in the US, and therefore there was benefit to be gained, and I'll get to window period in just a few minutes. In 2001 and 2002, then the IND studies led to the submission of license application, and FDA at that time licensed the first nucleic acid test for pooled plasma testing and for blood donor screening, both mini-pool and individual. I tried to come up with some sort of a graphic for this, and I decided to do a visual pun. Therefore, you see a kiddie pool representing a mini-pool. I tried. In 2003, FDA licensed the first test to detect HIV-1 group O, again recognizing that the diversity of HIV in some cases proved to be difficult for some tests to pick up, and so group O was then added to the tests. So where did this actually get us? I'm going to talk now just for a minute about window period. So with HIV antibody tests, this is shows you the kinetics of antibody. And the first generation, second generation, and third generation EIA tests. So the first generation test had a window period of about 65 days. With the second generation test, improvement in technology, the window period was reduced to about 45 days. And finally, with the third generation tests, which are used to screen blood right now for HIV-1 antibodies and HIV-2 and group O, the window period is reduced to about 22 days. If we look at HIV P24 antigen, the window period is reduced to 16 days. And finally, when you look at NAT, the HIV-1 RNA, which is studied in plasma specimens, the window period for mini-pool NAT is reduced to 11 days. And if individual donor NAT is used, then that's reduced to 7 days. So you can see the window period has been gradually reduced, so we can identify people earlier and earlier during the course of infection, depending upon the technology that's used. Now, this is goes according to the biology of the virus and the response to the viral infection. How does this actually play out in terms of making a difference? And that's shown in this slide. So here you can see that at the beginning in 1983, again, the risk was essentially 1 in 100 of a transfusion-transmitted infection of HIV. When the criteria were changed, the risk dropped. And what I'm showing on the y-axis is the risk of infection per unit transfused. When HIV antibody screening was begun, there was more of a drop. And then finally, when P24 antigen was begun, further drop. And then here with the implementation of nucleic acid testing, there's a drop even further. So you can see that the implementation of testing has certainly made a tremendous difference in the safety of the blood and has interdicted a large number of infections that otherwise would have gotten through. Just to put some numbers on this, from the graph, we're essentially dropping from a risk of about 140,000 or so, now down to, when mini-pool NAT is used, to a residual risk of 1 in 2 million, and when individual NAT is used, a risk of 1 in 3.1 million. Now, a lot of us deal with very large numbers, and so sometimes I'm not sure we really have a good feel for what that actually means, so I'm going to try to put this in perspective for you. If you would imagine a full football stadium, and that every one of the people in this stadium represents someone who has been transfused. Okay, this just happens to be a photo of Gillette Field where the Patriots play. This is in no way any endorsement by the FDA of the New England Patriots, but they always have sellouts, so it makes the point. So if you would imagine again that everyone in the stadium is infected with HIV, if everyone in the stadium is a transfusion recipient, then the risk is going to be 1 in 45 sellouts. That's what 1 in 3 million is for ID-NAT. So that just helps to put it in perspective how effective this actually is. That would be the residual risk. Now, I also wanted to make a couple of points here that I think often go overlooked, and I call these underappreciated and fortuitous facts. And the first one is available HIV testing technology is extremely accurate, and this is unlike tests for some other infectious agents. So HIV tests, in general, tend to have sensitivities and specificities that approach 100%. This is unheard of in the testing arena, and I'm not sure that I think we overlook that a lot. So, for example, when I speak with my colleagues in the Office of In Vitro Diagnostics at the Center for Devices at FDA, who deal with most of the diagnostics out there, if they're looking, we tell them that we're looking at numbers like this approaching 100%, they say they're just amazed at the sensitivity and specificity that these tests can achieve. The other fact I wanted to make you aware of is even though HIV continues to mutate at a very high rate, and there are numerous emerging variants, that diversity appears to not significantly impact detectability in most cases. This is a very important fact as well, because this virus is changing rapidly, and yet the technology is such that it has been able to keep up with it. At the same time, we don't want to be complacent about this. We recognize that there's always an opportunity for other variants to come into play that may not be recognized by existing testing. And so there are active research programs going on right now in FDA labs to monitor emerging variants and to evaluate the impact of HIV diversity on detection by current and future tests, such as HIV1 Group M, of course, is the main one. We've kept up with HIV2 and Group O. Then there's also N and P floating around out there, as well as the circulating recombinant forms. So just as I approach the end of this talk, I'd like to just take you from donor screening to diagnostics and back again as a bit of a segue to Bernie's talk, and to let you know that many of the donor screening tests that we licensed were actually given dual claims for diagnostic use, recognizing that the clinical trials that were done were sufficient to support the use of these in a diagnostic setting, and so that led to the first test used in the diagnostic setting. But we've also gone back the other way, which is very interesting, because we have recently, in the past year or so, approved the first HIV-1 antigen antibody combo test, detecting both HIV-1 antibody and P24 antigen at the same time. We recognize that there would be some value in giving a limited claim for donor screening to that test, and that would be for use in emergency donor screening situations, such that if you would encounter a situation when a traditional blood donor screening test might not be available, you could use a test such as this as an emergency donor screening claim, and we're in the process of working out some recommendations and guidelines for how tests like this could be used, but this is the future. We are planning on giving more claims like this in the future. So just to remind you where we are now, I've told you where we've come from. We're now back in the present, and as far as blood safety goes, the window period has been reduced to about 11 days in routine screening, which is done by mini-pool-nat. And there's the potential for reducing the window period to 7 days using individual donor NAT. The reason that individual donor NAT is not being used widely is simply, for a few reasons, technical and also efficiency. In a blood donor setting, you have a very, very low prevalence of HIV infection, and therefore the vast majority of people are not going to be infected with HIV. It makes more sense to devote resources to testing in a pooled manner. And so individual NAT is probably not the most efficient way to go. Also, the technology needs to catch up a bit. There are some systems out there that can screen using individual donor NAT, but the high throughput required in a blood donor setting is probably more amenable at this point to mini-pool NAT testing. And then also to remind you that the residual risk of HIV transmission in transfused blood is 1 in about 2 million using mini-pool NAT and 1 in 3.1 million for ID NAT. Also to tell you that there are new FDA licensed and approved tools for blood screening, for diagnosis, for very rapid testing, and for therapy monitoring, and this leads into what Bernie's going to talk about, and finally to bridge over into what Mike is going to talk about. Improved prevention and treatment are gained by having more people learning their HIV status. And with that, I'd just like to conclude by congratulating CDC for all of the extraordinary work that they've done with extraordinary people. And we at FDA are very proud to be a sister agency to you, and look forward to more and even better testing in the future. Thank you very much.
Thank you, Eliot. And like I said, unless there's any just specific clarification questions, I think we're going to go ahead and move on. The next speaker is Dr. Bernard Branson. He is the Associate Director for Laboratory Diagnostics here in DHAP at CDC. Dr. Branson has been involved in counsel and testing for more than 20 years in the HIV field. He was the lead author on the revised recommendations for HIV testing of adults, adolescents, pregnant women in healthcare settings. I think Dr. Branson is going to give you a nice overview of just the evolution of HIV diagnostic testing.
Thanks a lot, Michelle. Eliot talked a lot about tests, and I think what I would like to talk about a bit is testing, in addition to just tests, because I think that is part and parcel of some parallel development. As Eliot mentioned, in 1985, FDA licensed the first test, and CDC did something that was really somewhat unprecedented at the time by establishing publicly funded testing sites. When the tests were licensed for use in blood banks, there was some real concern that people who would like to find out their HIV status would go to blood banks in order to do it. And CDC established something called alternative test sites for people who wanted an HIV test as an alternative to going to the blood banks. And in fact, they sent CDC staff and EIS officers out across the country to different cities in order to talk about the test and their recommendations for testing. They recommended testing based on risks. It was the introduction of anonymous testing because of the stigma and the discrimination that could be associated with just seeking an HIV test at that point in time. And importantly, in 1985, the implications and the prognosis of a positive antibody test weren't yet known. There had been the San Francisco City cohort established for looking at hepatitis infection, and they followed those people for HIV. And when this test first came out, it was believed that only 10% of people who tested positive would ever go on to develop AIDS. And so a big message at that point in time was to try to distinguish between a positive HIV test and actually having symptoms of developing AIDS. In 1987, CDC conducted a consultation about the role of virus antibody testing in the prevention and control of AIDS. And at that point in time, the sort of process that has been in place for many years of pre- and post-test counseling was established. And in part, it was designed to explain HIV and how it could be transmitted and how it could be prevented, because very few people knew about that in the country at the time they were seeking a test. And so in that counseling process, you needed to explain the test, what the test result meant. And as I pointed out, a big emphasis at the time was to explain that having HIV at a positive test did not necessarily mean that you had AIDS. And of course, the counseling was conducted pre and post-test to encourage behavior changes. Big emphasis at the time was on confidentiality, on protecting personal information and personal rights. But one of the conclusions from this conference actually was that testing was an adjunct to counseling. It was felt that basically people seeking testing in order to get the test, it was a good opportunity to provide them with counseling. And because there was not any effective therapy, there wasn't much you could do with the positive test result, but it could be an incentive to help change behavior. And the technology remained relatively the same between 1987 and 2006. The enzyme immunoassay, or EIA, and the Western blot were the major standards for what happened with testing across the country. There was real concern about false positive tests, and as a result of that concern, in 1989, when CDC came out with recommendations for how to interpret a Western blot, they also recommended basically that no positive test results be given out to an individual until the screening test was repeatedly reactive and a supplemental test, like the Western blot, had been used to validate those test results. These were pretty stringent standards before giving out test results, and one of the consequences of that was that in the rest of the world, people began introducing rapid tests. In the US, this recommendation precluded that because you could not give a positive test result. I mean, you could give a negative test result and tell someone who had a positive test, I can't tell you on the basis of the results, but that really wasn't going to work, and it virtually limited the market to the EIA and Western blot in this country. As time went on, we started looking at what happened. Because you had to send a test to a laboratory because it had to be confirmed before the result came back, we noticed that one of the problems with this conventional testing is that since you had to return for your test result, many people never did so. And so many people never received an HIV positive test result. And as you see here from 1995 in red in STD clinics, only about half of people return to receive their test results. That's in the HIV negative column. And even with outreach, in order to talk to people and find the people who tested positive, about 1/3 to 40% of people who tested positive for HIV never received their positive test results. As a result, we began to look at other alternatives in order to help improve this. And one of the conclusions is that we needed to be able to use rapid tests to be able to give people same-day test results. And in 1998, the Public Health Service recommendation was changed to provide preliminary HIV-positive test results before the confirmatory results are available in situations where tested persons benefit. This included clinics where people went to seek their HIV test results. It also included circumstances like after a person had an occupational exposure from a needle stick, or for a pregnant woman where you might want to make a therapeutic decision immediately on the basis of a preliminary positive test result. As a result of the change in that recommendation, rapid tests came to the U.S. market, and between 2002 and 2006, FDA approved 6 different rapid tests for the United States. It was not only rapid tests that were important, but the concept of CLIA waived rapid tests. CLIA is another system of regulation for testing in the country. They classify tests on the basis of how complicated they are, and that determines who can do the tests and what requirements there are for proficiency testing and for monitoring. And 4 of the rapid HIV tests approved by the FDA, at least so far, 4 of them have received CLIA waiver, and those are pictured on this slide. They can be used with fingerstick blood specimens, they can be used with oral fluid specimens, and the key ingredient here is that they could be done at point of care. You could provide a result back to an individual relatively quickly, and they could be done by people who were not laboratory professionals. So that greatly expanded the range of where testing could happen in the country. By 2009, this is a survey from the National Association of State and Territorial AIDS Directors, over 61% of all testing that is conducted by health departments, in particular among high-risk persons, were CLIA waived rapid HIV tests. So as you can see, from 2006 through 7 through 8, conventional tests are in blue and the rapid tests are in purple. Rapid tests rapidly overtook and became the major form of testing that was used. At the same time, in CDC's organized publicly funded counseling and testing sites, while the proportion of people tested, the 1.4 million tests in 1989 to about 2.1 million tests in 2004, the number of tests went up, but the percentage of people testing positive went down. So that in the very beginning, very high-risk people were seeking testing. Nearly 5% of those getting tested were testing positive for HIV. By 2004, that was down to about 1.2%. In recent years, it's actually down to about 0.75%. So our publicly funded sites and our targeted testing based on risk was continuing to find infected people, but was finding fewer and fewer. And that led to the change in recommendations. Following the pattern of the number of people who had ever been tested, the National Health Interview Survey had asked questions every year about whether a person had ever been tested for HIV. And in the pink line on the slide, what you can see is that the number of people who say, or the percentage of people who said that ever been tested, increased between 1987 and about 2002 to around 40%, but then it stabilized. In 2002, about the same proportion of people every year said they had an HIV test. So our progress had really stalled in terms of testing more people for HIV infection. And so in 2006, as a result of this observation and a result of observation that many people who were going into healthcare settings had HIV infection but never got diagnosed, CDC issued revised recommendations for testing adults, adolescents, and pregnant women in healthcare settings. Previously, most of our recommendations for testing had been based on factors associated with risks for HIV, so it was targeted testing. And these recommendations called for routine voluntary HIV screening for all persons aged 13 to 64 in healthcare settings where the prevalence of undiagnosed HIV was at least 1 in 1,000. They also called for repeat HIV screening of persons with known risk factors at least every year, and specifically indicated that in healthcare settings where we would conduct HIV screening, prevention counseling, which had long been the mainstay companion of HIV testing, should not necessarily be required for people who were receiving an HIV screening test. This slide summarizes basically what has happened over time with HIV, the number of people infected, and the proportion who found out their infection. What you see in green are the proportion of people who are infected with HIV and who know they're infected with HIV. That number has increased so that right now, overall, there are about 1.1 million people who are infected with HIV in the United States, at least as of the end of 2008. In blue are the proportion of people who have HIV infection and don't know it. And the line that's going across that screen indicates what percentage of people are unaware of their HIV infection, which decreased from about 90% back when the test first came out in 1986 to 20% in the most recent year for which we have an estimate back in 2008. People always focus on the fact that 20% of people don't know they're infected. I think the impressive feature here is that 80% of people do know that they're infected. One of the other things that we see on this slide is that starting in around 1996, when effective therapy became available, the number of infected people in the country has continued to increase every year because survival is increasing for individuals. And so we have made significant progress in identifying people with infection and getting those people onto effective treatment. So there is a changing landscape, and I will talk a little bit about diagnostic tests that have been recently approved by the FDA. Originally, there was the EIA that was sent off to a laboratory. It was done in large batches and followed by the Western blot. More recently, there are platforms called random access assays, and although we've been used to saying EIA for a long time for enzyme immunoassay, the new tests are called chemiluminescent assays, and so they have a little different principle, but at least in these two platforms, one approved in 2006, another in 2008, these are machines in use in hospitals and laboratories where they can store 30 different kinds of tests, HIV, hepatitis B, HCG, which is a pregnancy test, and basically you just check which test you want on that, and so it can do a test one at a time, individually. Or you can put in an individual specimen and get a stat, an immediate specimen request in this platform, and get a test result back in less than 60 minutes from one of these procedures. There's been the qualitative RNA assay. RNA is an aid to HIV diagnosis. It can be used to diagnose acute HIV infection in people before they develop HIV antibodies, and it can also be used as a confirmatory test for people who are antibody positive when it's reactive. That was the first RNA test approved for diagnosis by the FDA back in 2006. Previously, there had been viral load tests. Those are used for monitoring. Those are not approved for HIV diagnosis. And so this did give us an opportunity to identify people even earlier in the course of HIV infection. And most recently, as Eliot mentioned, the fourth generation combination antigen antibody assays have been approved. And these detect the P24 antigen and HIV antibody. They run in that same kind of random access platform that I mentioned, so you can do one test at a time. You don't necessarily have to batch it. And in this particular test that's been FDA approved, you can get a result back in half an hour. One of the key ingredients that makes this combination test important is that while P24 antigen shows up early in the course of infection, it also disappears when antibody develops. And so if you only test for antigen, you'll find the early infections. If you only test for antibody, you'll find the late infections. But when you test for both, you can screen for people with both early and late infection using a single test. That's a lot more practical and a lot less expensive than testing with both an antibody test and an RNA test. So in terms of the sequence of what happens with tests, the Western blot has long been the mainstay of positivity, and these are data actually from Michelle's laboratory looking at all the FDA-approved tests with specimens from seroconverter panels and identifying basically when 50% of those specimens end up turning positive compared with the Western blot. So Eliot showed you the curve or the graph of different tests, and I'm going to show the specific tests so that the first test that was approved, the first generation or second generation test in use until 2007, the Varanasica picked up HIV infection about 2 days after the Western blot turned positive. The second generation test, this brand was RLAV, picked up infection about 5 or 6 days before the Western blot turned positive. The rapid HIV test, the CLIA-waived ones, pick up infection, again, between 2 and 5 days before the Western blot turns positive. The other rapid tests done in the laboratory pick up infection a little earlier, up to 10 days before the time the Western blot turns positive. And then the third generation test, most widely used for screening, and those 2 random access platforms that I mentioned, pick up infection about 2 weeks before the Western blot turns positive. And if we use an RNA test, it'll pick up people nearly 4 weeks before the Western blot turns positive. So as you can see on this slide, what's been happening is the sensitivity test has been marching so that infection is detected earlier and earlier. The 4th generation test we have a little less experience with, but it picks up infection probably 4 to 5 days after RNA picks up the infection. So we are now able to detect infection almost as soon as a person becomes infectious with the newest kinds of technologies. So in summary, I do want to remind us that 80% of people who are living with HIV in the United States have been tested and are aware of their infection. In order to continue this progress, both targeted testing for persons with risk factors and routine screening in healthcare settings remain necessary to identify the infections that we have not yet diagnosed. The tests that we have available are really good. They detect infection earlier, and they produce results a lot more quickly so that people can receive their results when they're in the healthcare setting. And finally, HIV testing remains an essential feature as the entry point for effective treatment and for effective prevention of HIV. Thanks very much.
So thank you, Bernie. We appreciate that. And so the next speaker is Dr. Mike Cohen, or actually Myron Cohen, but I believe he goes by Mike. He has a very distinguished career. He's actually a professor of medicine, a distinguished professor of medicine and microbiology and immunology and the public health at University of North Carolina at Chapel Hill. He also has a large involvement with the CHAVI group, which is the Center for HIV Vaccine Immunology. He's on the senior leadership group, and he's the chair of the NIH HPTN Prevention Committee. Welcome.
Good afternoon. I'm amazed that people are here at 3 o'clock in the afternoon. At a college campus, there's no one in any room. And if you work at a university, so the government employees must not, you're under different pressures than we are. And so I'll try and be brief and hopefully have slides. Do I control? Oh, I control the slides, okay. So we're going to go from a discussion of detection to kind of what do you do with the information about detection. And we're going to go towards the future, I think, as much as possible in this discussion. And the issues that I want to talk about are the fact that people have to be linked to care. The test in and of itself is not meaningful if someone either never gets the result or doesn't find their way into medical care. They have to have access to appropriate treatment, whether in the United States or somewhere else on the planet. And then if we simply find and treat, we can't deal with this problem with our current technology, because for every person we detect and treat, anywhere from 2 to 4 new infections occur. More people get infected. So it's a big problem, and one that we've been working for 30 years on getting a grip on. Now, I was asked to be anecdotal and make historical notes, so I'm gonna be, anecdotes are always good and history is good. So I think what's important to recognize is in the 80s, when some people in the room probably were not born, in the 80s, the disease held great fear and terrible prognosis and basically death. So 100% of the people who acquired this diagnosis died. And in 1985, I worked at the University of North Carolina, 10% of all our admissions were for HIV. And so that's a huge number. It's a 1,000-bed hospital. So at any point in time, we had at least 100 people with HIV in the hospital. We had at least 5 deaths a week. So it was a pretty terrible time. And people didn't really want to know their status, and especially because we had nothing to offer other than kind of modest management of opportunistic infections. In 1989, Frank Graham and Dennis Mackey wrote an editorial that attracted a lot of negative attention, or a lot of controversy, because they were pushing people to know their status even then, but then the controversy that evolved in a massive fight in the New England Journal was, why? Because this was fraught with not much benefit, but tremendous stigma, and maybe worst realized in Ryan White, who suffered terribly through no fault of his own as he acquired HIV from blood products in the early 1980s. And then in probably one of the biggest public health or biomedical events of the 20th century, AZT and then 30 more drugs were developed. And in this slide generated by the CDC, which I bet is one of the most shown slides ever anywhere, you see that as soon as we had access to antiretroviral therapy, deaths plummeted, and with the use of ART, deaths plummeted. And so this became a totally different disease. And most infectious disease centers in the United States developed outpatient clinics to take care of patients with HIV. The problems changed very dramatically with the development of this therapy. And the attention of the community of physicians involved in this moved to Africa and other parts of the world where there was no access to this kind of therapy. And so the world for many years, 1995 to 2000, 2001, was divided into people who could get access to pills and those who could not and would simply die. It was a very unpleasant time, and that's obviously, we've moved away from that. And as this particular discussion today focuses mostly domestically, we kind of need to be concerned that 80% of the epidemic is outside the United States. I want to thank the organizers, by the way, and my friend Dr. Merman for inviting me to be here today. So that kind of brings us forward. So now we have treatment, and the treatment is going to be important, and we'll talk about that. And then we also have to deal with prevention. And so prevention, we have 4 opportunities. Most of our time has been spent on people who are HIV negative, creating opportunities for them to remain negative. In this graph, you see that we have behavioral and structural activities that might take somebody who's HIV negative so they remain negative. And then we've got all kinds of developmental activities for people who are negative but are at higher risk. Vaccines, antiviral therapy is pre-exposure prophylaxis, topical microbicides, post-exposure prophylaxis. These are really important tools for people who are negative, know they're negative, and are at substantial risk. But then we've twisted recently pretty aggressively to worry about people who are HIV positive, who have been detected, are in the system or could be in the system, and to worry about creating an environment where these people are rendered less contagious. And probably the thing that's attracted the greatest attention in recent times, so for people who know they're infected, we only have a couple of options. We can have behavior change such that people are more responsible in their behaviors, use condoms 100% of the time, divulge their status to their partners. All of that, of course, is very positive, meaningful, and important. And there's a lot of evidence that does happen. But the other thing we could do is try to treat everybody. Now, in treating everybody, the idea would be if the treatment is so effective in personal health, maybe it renders people less contagious. And so this is an old idea. It's not a brand new idea. Most of us started working on the idea as soon as AZT was developed, trying to demonstrate that that drug would render people less contagious. And the tools that were used were trying to prove that that the drug led to fewer HIV particles in genital secretions. Then there were a series of observational studies, one of them done by Becky Bunnell here at the CDC, another by Patrick Sullivan, also at the CDC, and these observational studies were looking at couples, and they indicated when they studied couples longitudinally that when one partner when the couple was discordant, one person was positive, the other person was negative. When the positive person was afforded therapy, and then the couples were followed longitudinally, the anticipated transmission events occurred very rarely, vanishingly rarely. So these observational studies were consistent with the biological plausibility we thought existed, that antiviral therapy would lead to reduced transmission events. But we felt, for a variety of reasons, or the NIH felt, that a trial was necessary to understand the magnitude and durability of the benefit offered to antiviral therapy. So the trial that was launched was a very, very long and expensive trial called HIV Prevention Trial 052. And this had a study design that's shown on this slide. 1,763 couples were enrolled at 13 sites in 9 countries. Half the couples, and the couples are extremely well balanced. There's an equal number of men and women. They're enrolled with high CD4 counts. So the median CD4 count is 446, where historically people would not require therapy. Half the couples were followed and therapy was not offered for some period of time. Therapy was delayed until such time it was more appropriate for personal health. And the other half of the couples volunteered to receive immediate therapy at a CD4 count higher than would be traditionally used for therapy. But the purpose of the therapy was not so much their own personal health, although that was important. It was to determine whether that therapy would reduce the transmission probability to their sexual partner. Now, that study was supposed to go, the study started, was fully enrolled in May of 2010, and was supposed to end in May of 2015 or early 2016. But on April 28th, a Data Safety Monitoring Board indicated that while the study could continue, that the results had to be made public. And so this is a very unusual event because the study is ongoing, but the Data Safety Monitoring Board felt that the results were so important to the health of the public that it was irresponsible, or that the responsibility of the sponsor, the NIH, was to make the results public. So on the next slide, I show you the results that they were concerned about. Over the period of 1.7 years, there were 39 infections observed, 39 transmission events observed. Now, the total is not really important. What's important is the linked cases, where the virus could be linked from the infected person to their sexual partner. There were 28 of those, and this linkage is not something you can do at home. This is hard to do. It's a lot of sophisticated molecular virology. There were 28 linked cases, and among the linked cases, there was only one linked case in somebody receiving antiviral therapy, whereas 27 linked cases occurred in couples in whom no therapy was provided. This led to the conclusion that over this period of time, there was a 96% prevention of HIV transmission. Now, we don't know whether this will go on forever, but this is such strong prevention that it was felt that the public needed to know that these pills worked in this way. These were 97% of these were heterosexual couples. So this does not lend itself to knowing much about men who have sex with men. It lends itself to our understanding of heterosexual couples. The one transmission case is interesting. How is it possible that one person was able to transmit even though they were receiving therapy? The answer will be revealed later this summer when all will be told. All of the data related to this trial has not been told to anybody. It'll be presented at the Rome International AIDS meeting, which will have an online portion, and all the slides will be there. There'll be an hour and a half devoted to this whole thing. And then that one case will be described in tremendous detail. Something has to be kept in secret, even from my friend John. All right, so all of this lens, so now this becomes the infrastructure of a belief system. So now we're concerned about prevention, we're trying to find infected people, and now we're in a position to tell people who are infected, if you take your pills reliably, you'll probably become much less contagious, okay, especially if you're in a heterosexual relationship. This leads then to a question about population level benefit. That leads to modeling, and more modeling. So even while we speak, somewhere on the planet, a mathematical model is modeling something. Because, you know, there's plenty of opportunity if you're a mathematician to do modeling, because the assumptions provide the answers. So if I show you the next slide from a review article we wrote, and you ask the question, if you treat everybody, can you stop the epidemic? The green says, yeah, treat everybody and you stop the epidemic. These are models. The red is treat everybody and it'll have no big effect. So depending on your assumptions, you can have any answer you like when it comes to mathematical modeling. So we look at ecological studies. And we see two different kind of disparate points of view. We have investigators from San Francisco and British Columbia who have told us that they feel that enough ART has been used in those communities that they see reduced new cases of HIV or reduced incidence cases of HIV, but mostly they're looking at new diagnoses, which is a little bit problematic. And then we have other countries that are saying we're using a lot of ART and we're not seeing a population benefit. So I think what one can conclude from all of this, and this is a huge amount of information, is it's a really interesting topic. Treatment definitely, I think, reduces the probability of transmission from one person to another. And in order to see that benefit at a population level, we're going to need more information, both observational information, modeling information. And I like modeling a lot, so I don't mean to be negative about modeling. I just think we have to know that, you know, that the outcome depends on what we put in. And we're going to need experiments. And I'll get to the experiments in a second. So the experiments. So having said all this, the horse is way out of the barn. the species wants to know whether treatment can serve as prevention. And so there are several studies going on trying to treat large groups of people, treat enough people to stop the transmission of HIV. There's one in Botswana that's a pilot done by Dr. Essex. There's a study being done in the United States with the CDC called HPTN 065 in New York and in Washington to try and treat enough people to stop the spread of HIV. That's a pilot. There's a population ART study called PopArt from Uganda, in Uganda by the British. There's a treatment as prevention study in South Africa by Mary Elizabeth Newell. And then the CDC and NIH have separate competitions for very large sums of money that are going to be given out this summer to use combination prevention, using some combination of behavioral, structural, circumcision, and antiviral therapy to stop the spread of HIV. So these combination prevention trials are the way of the future, and this is kind of beyond modeling. The modeling says we have to do experiments. The experiment, these will be community randomized, large-scale experiments, which will, like 052, tell us we can do this or we can't do it. So it's going to be an exciting time, I think, in the prevention field. Now, and this, by the way, is just, this is a, oops, I don't know if I can go back, but apparently not. Okay, that last slide was just a picture of New York, of the community that's going to participate in 065. Now, unfortunately, as we try and use treatment as prevention, there are what I'm going to call inconvenient truths. Acute infections come up a bunch of times already. I'll say a word about that in a second. Drug resistance is a big issue. If we treat more and more people, we can run into trouble with resistance and convert the epidemic into an epidemic of more resistant viruses. And linkage to care is critical. This is acute infection. So this is a window of time when people don't know they're infected, their antibody is negative, and then as their antibody becomes positive, the process of ramp-up viremia transpires. As the virus grows to huge concentration, the person is rendered very, very contagious. In addition, each viral particle during acute infection is considered to be about 800 times more contagious than a viral particle from somebody with chronic infection. So there are two social forces. That's by Ma et al. John, I'm giving you the reference, Ma et al. Okay, so there's a lot of concern about acute infection. And then the question is, people are antibody negative during acute infection. They're hard to find. And even if we find these people, what do we tell them? What do we tell them about their sexual behavior? And should they be treated? We know we should treat people with more advanced disease, but should we treat people during acute infection? And there's no right answer to that. This is a graph from a paper published in the New England Journal just a few weeks ago that shows estimates of the contribution of spread of HIV from people with acute infection to other people. The lowest you get is 9%. Generally speaking. The highest you get is from our study in Malawi of 38%. And you can even get higher than that. But we argue that in Malawi, about 1 in 3 new infections come from people with acute infection. So this kind of emphasizes that even if we find all the people with chronic infection, we still have a problem with acute infection. And then this is a study by Bell, published in a supplement in JID, giving all the kind of ideas that relate to should we treat people with acute infection. Because if we find people and we don't do any prevention activities, and we don't do any treatment, we're back to, well, why did we want to find them? So it's expensive to find them, it's difficult to find them, and we need to get our act straight about this. And then lastly, there's this issue of, well, what's reality? A lot of people are unaware of their status. Those who are aware of their status are not necessarily in care. Some people are receiving medical care. Some are getting their pills. Some are fully diagnosed and in very excellent care. So not in care, engaged in care. This in an article by Gardner. But what's striking about Gardner's article, and these numbers are not necessarily 100% correct, but they have some veracity. And there's another paper by David Burns that says the same thing. If you look at Bernie Branson's argument that there's 1.1 million people who are infected, and then you accept that there's 875,000 who know their diagnosis, and then you look at the number not linked to care, it's a very large number not linked to care, or let's say linked to care is 660,000. Then you look at the number who remain in care and are fully suppressed in terms of their viremia. Gardner argues it's only 200,000 or 300,000. So if we're going to use treatment as prevention, how can this ever work if the denominator is 1.1 million and the number of people benefiting in the richest country in the world is only 300,000? How are we going to do this in Africa? How are we going to do this in Asia? Now, I'm not negative about this. I'm just saying we need to be really, truly realistic as we go forward, because it's the realism that helps us to succeed. So I'm going to end by saying this, that 30 years later, I've been working on this problem my entire career. Like, it's not 80 I saw my first patient, and it's now 2011, so I'm not on the fast track. This has gone on a very long time. But what I could say 100% for sure is this is a different problem than it was 30 years ago. This is a totally different disease, a totally different problem, a totally different planet. There is no doubt that HIV treatment is amazing. It prolongs life, and at least in the case of heterosexual transmission, we're now 100% sure that we can slow the transmission when we find people and offer them excellent treatment. So there's a double benefit to knowing your status and being treated. So the challenge for us is the last statement, to assure that HIV detection that allows knowing your status leads to the remarkable personal and public health benefits that are possible. How do we as a kind of human beings take all this information and translate it into the most meaningful thing we can do for health of the individual and health of the public? So thank you for listening. Thanks.
Thank you. And now we will take questions.
Thanks a lot. There's just a couple of observations. First is probably a quote I'll use often, and that's, it's the realism that helps us to succeed. Thank you for that. I need to use that really a lot. Another just sort of observation that I hadn't noticed before is while deaths decreased after the advent of HIV treatment, incidence stabilized at that point too, and I really hadn't noticed that before, but that's about the time that it stabilized in 97, 98 is where we started stabilizing incidence, I believe. But the top, oh, here we go, it's back. In terms of diagnostics and testing and the role of acute infection, I'm really struck by the commitment we've had in Eliot Cowan's presentation, the commitment we've had to keep the blood supply safe, the tremendous expense to do pooled NAT testing for a very safe blood supply. I guess I'm curious what we think the importance of detecting acute infection, particularly for high-risk people, is, and how much we should commit to doing that. It's kind of a tough question, but is it worth it as much as it is to the blood supply, and should we be going for it?
I think both Mike and I will try to tackle that question about acute infection. It's obviously easy with the blood supply, because if you detect acute infection, you don't transfuse it, and therefore, end of story. Acute infection for people, and Mike and I don't always entirely agree on what the importance is, but in the beginning of the epidemic, everybody has acute infection. And so obviously it was very important to look for it. At the current time, what we recognize is that acute infection and its importance is probably related to how much of it is in whatever population is experiencing it. So in the MMWR article on men who have sex with men that came out just a couple of weeks ago, what we recognize is that nearly 20% of the people who were infected but didn't know it had had a test within the last 3 to 4 months and were told they were negative. And so I suspect that many of those people would have been detected if we were looking for acute infection. And because we know that's a high incidence group, it's probably very important to look for acute infection. On the other hand, well, first of all, so if a person gets tested, if they're infected, we want to tell them they're infected, so detecting acute infection would be important. People who find out that they're infected tend to change their behavior, so they become 3.5 times less likely to transmit, so it makes a difference in terms of the epidemic. The big question, and that was on one of Mike's slides, is whether treating people with acute infection makes any difference, and that is, I think, so far an unanswered question, and maybe I'll turn it over to you at that point.
Well, those are really good questions, to be honest, and there's no right answer. The first thing about incidence, we have a lot of trouble. Michelle's, I think, worked for many, many years on better incidence assays. We have a lot of trouble understanding incidence. First of all, newly detected cases are not incident cases. Those are people who acquired virus many years earlier, and now they're a new case. And that is often confused somehow by people who, should not confuse it. The true incident cases we have a lot of trouble with unless we're looking at seroconversion cohorts, and so the incidence in the United States has been estimated a lot of different ways at a lot of different numbers over the years. So I'd be hesitant And we're very interested in reducing incidence in the United States, but given how much trouble we have in measuring it, we have to be very careful about declaring success or failure. And so what am I saying? I'm saying when I look at the slide and those numbers, I'm not 100% sure kind of how much variability there really is given our difficulty in detecting reality. In terms of then, and this is where we wouldn't disagree, it's very straightforward in a sense. People with acute infection, there's no doubt they're very contagious. Their contribution depends on how many they are and how many sex partners they have and how long they remain contagious. People with chronic infection, untreated, are always going to overwhelm and number the people with acute infection. But they're going to be less efficient in their transmission. And so they're going to have opportunity to have more sexual episodes without a transmission event transpiring. So a small number of people with acute infection can create a very large problem. And what happens in the, and as everybody would recognize, everybody has acute infection at some point, although most of it's unrecognized. So if you look at couples, and it always takes 3 people when we're talking about sexual transmission. So you have a concordant negative couple, they're minding their own business, and a third person gets into the relationship. When that third person gets in the relationship, well, that's exactly what happens. The third person, and hopefully none of you are suffering that, you know, but our species is confounded by 3 people getting into a relationship together. They just don't know they're all in the relationship. When the third person gets in the relationship and a transmission event occurs, often from a chronic person to the unrecognizing partner, then the transmission event occurs very quickly to the next partner, rendering 80%, 70 or 80% of couples in most places concordant positive. And that transmission event probably occurs in the first 5 months. By all our estimates, it occurs pretty quickly. So again, it emphasizes the importance of acute infection. Now, one argument with Bernie, we have an article in The Lancet this week from Malawi that's got a very chronic epidemic, and we claim in that article, and it's a modeling article, so let me criticize myself for modeling, but it's a modeling article essentially, and it says, look, we think about 1/3 of the cases in Lilongwe, Malawi, even in the mature epidemic, are being ascribed to chronic acute infection. That has to do with these relationships, these sexual relationships. So it's a long-winded answer, I apologize. And lastly, we don't know how to, in terms of resources, I know of no one who could tell the right way to allocate resources, because you could waste a lot of money trying to find a few people with acute infection or not, you know. And the blood bankers, I think they spent, it was estimated by by the Yale people in the beginning of the epidemic, that they spent like $80 million for the last 8 cases or something. There was a very famous paper about what was required to make the blood supply safe, and it was absolutely required, but it was terrifically expensive. Is that true, Eliot? That the last 8 cases or 10 cases?
I don't know that.
Yeah, it's very expensive.
Do we have any questions out in cyberspace for the speakers? No questions? Okay. Well, actually, I have a couple of questions, and actually, one just occurred to me off the top of my head, and you were actually talking about when you were talking about the success of 052, and it was great because it was a very controlled study. Like you said, you told me, you know that people are on therapy because you can look at them. So actually, I have a question that has to do with testing, but kind of a different testing question. How valuable do you think it would be to have a test that could rapidly detect whether or not someone is compliant with their therapy? So you could actually test, instead of just testing to see if they're infected, but are the meds present?
I mean, 100% for sure. A point-of-care rapid test that shows viral suppression is one of the holy grails of both treatment and prevention. So it's extremely important, because if the viremia is not present, it means that the people are adherent, and that they haven't acquired resistance. So you get 2 things for one. A lot of people have been working on this for a long time, this kind of holy grail dipstick test.
So I'm saying not just an HIV test, but actually a test that could tell you if the drug was present as well. So basically a test to measure compliance of actually taking drugs. Do you think it's useful?
I don't know. What do you think? I'll explain.
Well, I think I agree with Mike. I think the more important thing in the HPTN 065 study, that's ultimately what we want to look at, is whether virus is undetectable in people. Because if drug is there but virus is still detectable, that doesn't help you answer the question. And I think that, as Mike was pointing out, it's not only this is the holy grail, but actually we're close. I think there are several prototypes now of point-of-care tests that will be able to look at whether or not people have detectable virus, and that I think will be the next game changer in terms of both monitoring therapy and helping to look for people with acute infection.
This is Jonathan Merman with CDC. I just had a question. Thank you for wonderful presentations. One of the issues, Mike, that you kind of highlighted was the fact that technological innovation has played a large role in the changes that we've seen over the past 30 years in the HIV epidemic, but it's not enough. So, for example, condoms prevent HIV infection, but not everyone uses them. Tests to detect HIV became available, but there's still 1 in 5 people in the United States who have HIV don't know they have it. And antiretroviral therapy is extremely effective at prolonging survival, but not everyone is accessing it or taking it. I had a question for you regarding rapid antigen tests. The idea that we'll soon have on the in the market available to people sometime in the next few years, a test that will detect antigen as well as antibody very close to the time of infection. And my question for people on the panel is, once that technology is available, how do you think people would and should use that test to reduce transmission and acquisition of HIV?
A really good question, and this is Bernie may have a different opinion. I think if such a test becomes available, it's really important, and it'll filter in. So, first of all, there's 33 million people with HIV, 36 million with HIV infection living. They all had acute infection. But the number of people that kind of present to a physician or a healthcare provider with acute infection is vanishingly small. But then whenever we do these retrospective studies, every single one says that like 90% of the time or 93% of the time, when you really question the people, you could figure out the day that they acquired infection, they were sick, they had a fever and a rash and so on and so forth. So I suspect, but this is unknown to me, this is a suspicion, that people actually are sick when they have acute HIV infection with a self-limited illness. And I suspect if we have the test you're describing, and it's approved by Eliot, and it's in a physician's office, and I think for higher risk patients and for general patients, it will be used pretty readily in combination with another event that I think is going to transpire. So the first event is physicians will be aware that there's this test that they can use in a mono-like illness and a febrile illness. It will no longer just be, well, I don't know what to do about it. It'll be like, let me make sure you don't have this thing. But then recognizing people have acute infection, we're going to have to be aggressive then. Mm-hmm. So I think that kind of lends itself to the future. And there's two parts of the future. One is we're going to end up treating people with acute infection. That's the first. How strong we believe it's of benefit or not, it's going to happen anyhow for a whole bunch of reasons. And second, we're now into the cure AIDS window. This week NIH will describe, this week or next week NIH is going to release many, many millions of dollars. I think $50 million for a cure AIDS grants. And that's going to really get a lot of attention. It's like, whoa, we're really going to try and do this. Now, even if we don't cure AIDS, the way we approach the problem, that'll be applied to people in a way that makes HIV disease much more like cancer, remission, if you will. And then, so that whole movement will favor what you've just said. That is a test that doctors can use and they'll think, I better know this because if this patient has acute infection, they're going to go into the kind of cure AIDS window. And it's all kind of coming together over the next 20 or 30 years. This is not a 1 year, this is not the fast track. But, we've been into this for 30 years. There's like another 30 years, at least, in front of us.
I think I have a little different perspective, perhaps, on the question that you're asking in that I think that it is very unlikely if someone met a person they wanted to have sex with that they would run to the doctor in order to get a test at that point in time. And we had, well, you are a doctor, so that's a different situation. We had done focus groups looking at this concept of self-testing, of consumer-controlled testing, several years ago. And people were interested in doing that. One of the recommendations was they should be sold in 2-packs if you were going to do it, because both partners need to be tested. But at that point, when there were only antibody tests available, people were very worried about the window period and the prospect for infection at that time. There currently is at least one manufacturer that has applied for approval of a home use or a self-test for antibody only, and the prospect you're raising of an antigen antibody test that would detect almost everyone who was infected very early on could really empower people in order to make decisions about what precautions they needed to take or what actions they wanted to take in terms of protecting themselves. And so I think that assuming it can be done affordably, it could have a tremendous effect on allowing people to take control of their lives and of their opportunities for infection.
I want to add one thing we didn't talk about. I want to add one thing to what Bernie said about home testing and much more broad, easy to use tests. The pre-exposure prophylaxis deal we haven't talked about. Those drugs, we have the drugs. We know that they work at some level for pre-exposure prophylaxis. We know CDC is trying to develop guidelines or recommendations. But I think for sure, whatever those recommendations end up being, that much more frequent testing of people who choose to go that route is going to be essential. Because if you're taking those pills and you don't test yourself or get tested very, very frequently, the chance that you'll end up with a resistant virus becomes very, very high. So I think one of the issues about much better availability, whether it's antigen or antibody or just antibody tests, that they're going to be done. If we're going to use pre-exposure prophylaxis effectively, testing is going to be a big part of it. And we really didn't get into that, but I think you agree with that? Yeah.
And just, Eliot, from your perspective, what level of sensitivity and negative predictive value would you need, or would the FDA essentially need, to see in an acute HIV infection test to actually even engage with discussions about it being available to the public?
Now, are you talking about a home use test, or are you talking about just a professional use test?
Probably home use is where the complexities evolve most
well,
most
for
strongly.
home use, we've already had some public meetings to talk about the types of performance that we would expect. And it was a very interesting discussion because obviously this is a very politically charged issue. You have people who are very passionate on both sides of it, make home use available, don't make home use available. But the advisory committees had given us the green light or recommended that FDA could actually proceed along these lines. Now, having said that, we talked to them about performance levels. And currently the acceptable performance levels for professional use rapid HIV tests are 98% sensitive and 98% specific as the lower bound of the 95% confidence interval. Taking the statistics out of the equation here, what that translates into is sensitivity and specificity 99.5% or greater, just so we understand that. And that's what we would expect for a professional use test, be it just antibody as they currently exist or antigen antibody combo. Now, when we got to the home use situation, we had proposed that the levels be dropped to 95% as for both sensitivity and specificity as the lower bound. The reason for that was we didn't want to put too heavy a burden on the manufacturers and to do something which would be more realistic, recognizing also that when you take a professional use test and put it into the home use setting, you're going to see a deterioration in performance. So that was the rationale. And then there was some very interesting discussion, as I mentioned, at the advisory committee, which was one person even suggested that we drop it to 90% because of the perceived need to have a test like this available, but the committee decided that no, 90% was just too low. So where we are right now is at 95% as the lower bound. And again, that's going to translate into higher, it'll be about the low 90s, I guess, something like that. I'm sorry, low 99s for sensitivity and specificity. The other interesting thing that was that we found out when we did a risk analysis on this, by the way, drifts off a little bit, but I think it's very relevant, is that when we contacted our colleagues at CDC to ask who would be most likely to use a test like this, the overwhelming majority of people who would be using a home use test would be low-risk people. And so what that did is it put the emphasis on the specificity of the test. So if you have a slight drop-off on the specificity of the test, your positive predictive value just plummets. So it's looking like the specificity for these tests has to be very, very high. The sensitivity should be high also, but we're really going to see a big impact on the specificity. So right now we're on record as saying 95% is the lower bound is the criterion you have to meet, but at the same time we're going to be working with our risk people so people understand what the implications of that are.
Can I ask you a question, Eliot? I mean, the problem I have with that, and maybe John, you might want to comment on this. The problem I have is if the test is used like kind of traditionally would be the case exactly as you said, of low-risk people. I understand it exactly. But if it becomes the PrEP test, and it's used by gay men who are taking pre-exposure prophylaxis, let's say there's 500,000, then 95% sounds to me like a terrible number, because that sensitivity is way too low, because you'll force resistance. That'll happen very quickly if they're just taking Truvada as their PrEP. So would you reconsider it if CDC's got, you see my question. I mean, if the test is used, maybe you'd have to have two different kinds of tests.
With different indications, perhaps.
Well, yeah, because that would worry me if 95% doesn't sound right to me if people are taking pills and they're retesting themselves every month to prove that they're not hurting themselves with the pills.
Yeah, it's a very interesting idea. It's something we might consider. We should certainly talk about this more, and should be part of the more general discussion, I think. But at the same time, part of that discussion might involve looking at having different intended use claims, for example. Interesting idea.
Thank you.
Good afternoon. My name is Brittany Hughes. I'm an intern here at CDC. And I actually have a question for you guys that comes from an individual who's been following the lecture via Twitter. So they want to know, as far as HIV testing is concerned, can you speak about what support is available from the insurance industry for the public?
Can you repeat the question?
Sure. Okay. They basically want to know, can you speak about what support is available from the insurance industry as far as HIV testing is concerned?
To be honest with you, the regulations for the insurance industry in terms of providing support to people are state by state. And states have specific requirements in different places about what they require insurance companies to do. And in most cases, the insurance company will only do what is required for them in terms of HIV testing. There are certain states that basically say you only provide an HIV test result if the person requests it. And in general, they don't have as stringent requirements for providing support to an individual after they've been tested, whether they test positive or test negative, as almost any other environment for testing does provide. So I think that, again, that's a question that we can't answer on a national level because each state makes its own decision about what they require insurance companies to do.
So has there been any discussion on a national level about standards that we would put in place for HIV testing for the public?
There's not been a discussion on a national level because we can issue a recommendation, but we can't set a standard or put in a regulation the way states can. So obviously CDC has long encouraged people to provide results, to provide support at the time of results, to provide access to follow-up as a recommendation, and certainly that recommendation won't change, and that applies whether you're an insurance company or you're a doctor or you're a blood center doing the screening. That's across the board.
Okay, thank you.
Hi, Eva Margolis at CDC. Bernie, my question's for you. As you were talking about the advancements in the tests, I just wondered, to the extent that if we were to change our testing algorithms, to what extent would state laws prevent states from adopting our changes in state testing algorithms? I mean, in testing algorithms.
Eva, thanks for asking that question. As I pointed out, we've all been used to one algorithm, one way of confirming testing, which is with the Western blot. And we clearly know that now that the tests are a lot better, we need to do something different than we have before. It was actually a question Michelle promised that she might ask, is what we would do next. So thanks for doing that. What CDC is in the process of doing right now is looking at some alternatives that will potentially do a better job of confirming, that will do a potentially less expensive job of doing confirmation, and with a faster turnaround time in most cases. We have been in communication with a small number of states that have very specific requirements in their legislation. In other words, some states, when they passed their laws in the 1980s, insisted that you could only do a Western blot for confirmation, and actually Illinois just changed their legislation this year in order to make it compatible with what CDC recommends. But part of our process is to, number one, recommend the algorithm, and then to take steps with any of the states that do have regulations to ensure that they end up making those regulations consistent with the newest recommendation that takes advantage of the best technology.
Okay, thank you.
Do we have any other questions from the audience or from cyberspace? No? All right, well, it looks like we're also right at our time at 3:30, so if no one has any other questions, I want to thank all the panelists and all of you for attending. Thank you. And I'm going to say one last thing as you're leaving. Please don't forget this is a lecture series, and the next one will actually be on July 14th, and it's going to actually be at Morehouse, and you can get more information about that on the 30th anniversary neighborhood.